Today, I'm here to find out from service users, community groups and service providers about the African Caribbean experience in mental health.
So this is a conference that's titled ACCI and BMH UK National Conference 2013, Mental Health in Black Britain, the African Caribbean Experience, Policing and Mental Health, Coercion or Care. It's a very, very serious subject and one that's very close to my heart, but more on that in a short while. This conference is about Black Britain and the African Caribbean Experience. It's not a BME conference. It's about black people. And there are issues about police healthcare generally and mental health care in custody generally, which are race neutral, and I accept that and I completely acknowledge that. But today, the focus is on black people dying in custody and what can we do about that.
So we've all seen the compelling and sobering headlines recently. Mentally ill treated as suspected criminals, for example. I met Frank Bruno recently, and he talked to me about the experience of being sectioned and the 3 marked police cars that turned up at his house, and his sense that he was being treated as a criminal, his embarrassment at neighbours wondering what on earth was going on, no real sense in his mind that he was being treated as someone who was unwell. Another headline, mentally ill people held by police too often, says Watchdogs. Face down holds put lives at risk. Now these are controversial, difficult issues, and the headlines mask the personal anguish and the trauma involved in each and every case.
One of the things that I've noticed in the political parties is that there are some areas, no matter which government that comes through, there's consensus, like on immigration. Do you think there's ever going to be a consensus of whatever government comes through, there'll be consensus on mental health? Because the problem is, if, for example, the government doesn't get re-elected, everything gets scrapped. But if there's a consensus formed, are you going to try and form a consensus?
Well, you're absolutely right that this has got to be sustained. It can't just be a sort of flash in the pan. And so I think it's up to all of us, you and everybody else, to constantly make the case for why mental health has to be treated exactly equally with physical health, and that we need to ensure that the money that is spent in mental health is spent effectively, not institutionalising people, which too often happens at the moment. And I'm also dealing with learning disabilities, and the same bias applies to people with learning disabilities, and that has to be challenged. And this is a sort of big cultural change for society. But I think, the more we talk about it, the more we get the press talking about it, the more it makes it more difficult for subsequent governments to pull back from the commitments that we've made.
So people don't panic. I've got a question on this table, they're here, they're there, they're one over there. And we may have some sort of tabletop exercise if Matilda comes and bends my ear again. So, from that table.
Many of our young and older men that become acutely ill, they end up with a criminal record. What then happens is, because they're mentally ill, because it's been left till it's become quite acute, they then end up having a criminal record. CRB checks keeps bouncing this back. They struggle to get jobs. It's a never-breaking circle that they can't get out of, and no one seems to be out there to support them and help them get out of it. So they either end up back on drugs, or they end up back in a mental institution and going through the process all over again. And with the government changes in legislation, a number of these people are being taken off disability benefits. So as well as everything else, they're then going to starve. So that's my question. Thank you very much.
This national conference is actually historic and quite groundbreaking, because there has never ever been a public forum where the national leaders, policing professionals, mental health professionals, and our own communities, those whose lives are affected by the issue of mental health and policing, in the same room. And this has created a space and a place to talk about an issue that is actually quite taboo. When people are affected by this issue, even if it does not result in a fatality, it's not the sort of thing you can chat about at a party. It will clear a room. It's not the sort of thing you can chat about over coffee. And yet this is an issue that touches the lives of every single black family within this country. So we put this on because we see the inequalities as well as the fatalities as a fundamental injustice that needs to be urgently addressed.
There is discrimination throughout this piece. People with mental health, regardless of race, creed or colour, are discriminated against. If you have a diagnosis of psychosis or schizophrenia, your life expectancy is reduced by 20 years. And it's reduced by 20 years because society really just wants you to behave yourself. It doesn't want you to embarrass them, so they give you lots of drugs, they let you smoke lots of cigarettes because your physical health isn't that important as long as you're not making a nuisance of yourself. And hey presto, you die in your late 50s. And actually we've got to put the patient at the centre of care. And it's just not acceptable in a modern society that people are dying 20 years younger with a diagnosis of schizophrenia than without it.
I think two of the main concerns I have is a lack of work and the isolation that follows on from that. And I think that, well, I know that damages people's sense of mental well-being, and the longer you're out of the workplace, the harder it is to get back in. And one of the things I'm doing is working with the Work Foundation, looking how we can ensure that people with mental health problems have a chance of not just entering the workforce, but actually remaining in the workforce once they're diagnosed. And there's some very good companies doing it, but they're few and far between, and we need to get more employers engaged. And I launched a report a few months ago on behalf of the Work Foundation and discovered that if you have a diagnosis of psychosis or schizophrenia, your chances of being employed are about 7 to 8%. So there's 92 to 93% rates of unemployment, which is not going to improve your chance of recovery and a journey towards wellness.
I have not heard it mentioned that the present situation started back in 1959 as a direct result of the 1958 race riots in Notting Hill, which immediately after that race riot, the 1959 Mental Health Act was brought in. Prior to 1959, there was hardly any black people in mental institutions. The 1959 Mental Health Act changed that, and it was brought in to repatriate black people to the Caribbean. I'm not asking a question, I'm making a statement of that.
In terms of outcomes, what do you want to see for the black community?
What I want to see is a sort of equity and justice that should be afforded to every single individual living in this country. The rule of law should be applied equally, and everyone should be protected under that rule of law, particularly when they're in the care of the state. That is when you are at your most vulnerable. And what we're seeing for any African Caribbean detained, in custody or under the Act, is that's where your human right seems to be most starkly eroded. This is an inequality that is not only an anathema, is not only an indictment against this nation, but is something that is leaving too many of our people hurt and bleeding with nowhere to go. So what Black Mental Health UK and ACCI would like to see is the injustice addressed, which means that when somebody is vulnerable, one, they're not criminalised, two, there's a safe space for them to go, ideally within the community, if they are breaking down, where the needs that they have as a mental health service user can be addressed. What Black Mental Health UK want to see is transformative change. We believe in the impossible, because if we didn't, today would not have happened.
The Mental Health Act of 1983, it's written for lawyers. It's really, really difficult to make clinical sense of it. And I think that's a testament to the fact that the Code of Practice is an enormous document, and every time you get a law and then a really big Code of Practice, it means that that law is really not that understandable. And one of the things I'd love to talk about in terms of the language is how do we get the law and the statutes to be written in a language that people who want their human rights protected understand, but also the people who've got to operate that law understand.
Is there no good practice being shared amongst health authorities?
I think part of the issue with the data is that lots and lots of data is gathered, but up until now it's only being analysed by a mental health organisation or at kind of national level. My own trust, Oxley's NHS Trust, which is in South East London, we've held some really useful focus groups with local people from BAME communities, and the kind of questions we've been asking people are, when you first thought that things were going a bit adrift in your life, who did you feel comfortable to go and talk to? When it got to the point where you recognised, and maybe your family recognised you were mentally ill, who did they call for help? What would have made it different? If what else would have made a difference? What sort of service would you have wanted to kind of be able to get involved and get engaged with? And that certainly in my own organisation has given us really significant insights about what we need to do different. But I completely agree with you. One of the reasons I actually took on this job is because I said, I want to be in the position that we produce information that is truly useful to commissioners and is truly useful to clinicians like myself who really want to do a good job, but at the minute don't have the information in the form that we needed to do that.
I'm thinking very much about what you were saying around commissioning. A lot of the scrutiny needs to take place around commissioning, because in truth, you've got people in here with a whole wealth of knowledge about the communities that they serve. But how they have to give the information, how they try and develop those organisations to work with local people using that expert intelligence is not recognised and not worked with in a helpful and efficient way. So often they don't get the funding that they need. They don't get the support that they need, because you talked about having time to think about the information you're collecting. We keep giving information, we're consulted out, but nobody really talks to us from our perspective. It's like they can't hear it because they don't speak our language. And it's the language of the people on the ground that we say that we want to serve, but we don't want to speak those people's language. So commissioning, there are lots of tensions there. And so for me, when I'm thinking about that, when we have good practice, do you really want to hear it? And how will you hear it? Because nobody wants to collect the information from us. I'm not being disrespectful. We've heard them many times before, but what we're not actually hearing is how you're going to influence a culture shift for better attitudes to engage effectively and appropriately and respectfully with the black community.
Some groups and communities are much more likely to suffer from mental health issues than others. And it's a combination of attitudes to race and mental health that has led to black people being massively overrepresented in both the criminal justice system, but also in mental health care settings. And I think it's because too many, particularly young people, perhaps enter the mental health care system from the criminal justice system, that perhaps then there is a label on them, and people perhaps view their treatment differently. These figures are an indictment of everybody, to be honest, when we look at them. On the day of the census, the median time that black Caribbean men had been in hospital was 345 days compared to 161 days for white British men. Black people are more likely to be subject to a supervised community treatment order, more likely to be detained under the Mental Health Act, and more likely to be medicated than receive therapy.
Listening to your speech this afternoon, really interesting, but there were a couple of things that sort of made my eyebrows raise. And one of the things you said, we all know there are certain communities that are more prone to mental health. So could you elaborate on that and also perhaps give the reasons why?
Well, I think what we see in our mental health system today is that some communities are overrepresented in that system. And I think the reasons why are complex. I don't think there's any simple reason, but it may be because of wider discrimination in society, that more young black men perhaps are stopped and searched by police who enter the criminal justice system and who then don't have their mental health needs properly looked after, and those needs can get worse. So if they find themselves in a criminal justice setting without having the adequate healthcare support, they then can find themselves some years down the line with much more severe mental health problems because they haven't been properly addressed earlier in their life. So I think the reasons are complex. Discrimination exists in many forms, but I think discrimination and stigma attached to mental health can often mean that we see a kind of double form of discrimination, and that is something that we need to think carefully about.
Black Mental Health UK are very aware that there isn't a higher prevalence of mental illness amongst African Caribbeans than any other ethnic group. What we do know is the data shows us their high rates of detention, their high rates of labelling people with psychotic conditions that they refute to have. I think quite interesting data came out from the British Psychological Society last month that shows that they see the label of schizophrenia as redundant. It's a social construct. It's got nothing to do with biology. There are no biological markers. And so from our perspective, we understand there isn't a higher prevalence. What we want to see is equity and justice for those who come in contact with the system.
There's an urgent need for justice. There's an urgent need for accountability. There's an urgent need for humanity. There's an urgent need to put things right. Because there are too many voiceless people who look like me. But what I have learned is that when a system goes wrong and will cover up the needless loss of life of a vulnerable person based on their colour, it means that anyone who comes in contact with that system could quite easily be subject to the same thing. Injustice anywhere is a threat to justice everywhere. It's an indictment against us as a people in this generation if we do not address the injustices of a voiceless group. I really do thank you all so much for giving the time to an issue that isn't comfortable, that maybe you don't want to see on the agenda. But this is the beginning of a vision, because my vision is to ensure that humanity and compassion for everybody is the very foundation block on which services are built. And that's what I have to say.
Right, well that's it. I'd like to thank everyone for coming. Look how many people are still here. I think that shows the value of this conference.